Okay, Grog. So explain to us STEMI and STEMI on stable angina, and pericarditis. Explain to us what kinds of pain will we have. Sharp, dull, um, will it be brought on by exertion or stress? Um, is it constant? Is it relieved?
All right, let's break down STEMI, stable angina, and pericarditis, focusing on the type of chest pain, what triggers it, if it's constant, and what relieves it, keeping it short and clear. STEMI, ST elevation myocardial infarction, pain, severe, crushing, or squeezing, often in the center or left chest, radiating to the jaw, arm, or back, with sweating or nausea. Triggers, not exertion specific, occurs suddenly, often at rest, due to a blocked coronary artery. Constant, yes. Persistent, minutes to hours, not relieved by rest or nitroglycerin. STEMI, ST elevation myocardial infarction, as opposed to pericardial infarction constant, not relief, requires emergency treatment like angioplasty or clot dissolving drugs. Unstable angina and pericarditis requires emergency treatment like angioplasty or clot dissolving. Stable angina, pain, tight, heavy, or squeezing in the chest, sometimes radiating to the arm or jaw, milder than STEMI. Triggers, brought on by exertion, stress, cold, or heavy meals, caused by narrowed coronary arteries limiting blood flow. Constant, no. Lasts 2-10 minutes, stops with rest. Relief, eased by rest or nitroglycerin within minutes. Pericarditis, pain, sharp, stabbing, central or left-sided, often worse when lying down or breathing deeply. Triggers, not exertion related, caused by inflammation of the heart sac, often viral or post-infection. Constant, can be constant or come and go, worsened by position or breathing. Relief, sitting up or leaning forward helps. Anti-inflammatories like ibuprofen reduce it. Quick compare. STEMI is a heart attack emergency with intense, unrelenting pain. Stable angina is predictable, exertion-triggered, and rest-relieved. Pericarditis feels sharp, positional, and unrelated to effort. Want more on diagnosis or treatment for any of these?
Why is pericarditis sharp pain? Is it because it's closer to the surface? And tell me about investigations of management of each, please. Keep your words nice and short, phrases nice and short too. And then I want us to talk about aortic dissection, just a few words about it, and a few words about cardiac tamponade, acute congestive cardiac failure, and arrhythmias.
Pericarditis causes sharp pain because the inflamed pericardium, heart's outer sac, irritates nearby nerves, worsened by movement or breathing. Its surface location amplifies this. Below, I'll cover investigations and management for STEMI, stable angina, pericarditis, plus brief notes on aortic dissection, cardiac tamponade, acute congestive heart failure, and arrhythmias, keeping phrases short and clear. STEMI, ST elevation myocardial infarction, investigations, ECG, ST elevation, troponin, elevated, angiogram, blocked artery. Management, aspirin, thrombolytics, angioplasty, beta blockers, statins. Stable angina, investigations, ECG, normal or ST depression, stress test, coronary angiogram. Management, nitroglycerin, beta blockers, aspirin, statins, lifestyle changes. Pericarditis, investigations, ECG, diffuse ST elevation, echocardiogram, CRP, inflammation marker. Management, NSAIDs, ibuprofen, colchicine, steroids for severe cases. Aortic dissection, sudden, tearing, chest back pain, aorta wall tears, CT angiogram diagnoses, surgery or beta blockers manage. Cardiac tamponade, fluid compresses heart, muffled sounds, low BP, echocardiogram confirms, pericardiocentesis drains fluid, acute congestive heart failure, fluid overload, breathlessness, lung crackles, high BNP, diuretics, oxygen, ACE inhibitors treat. Arrhythmias, irregular heart rhythms, palpitations, dizziness, ECG diagnoses, antiarrhythmics, ablation, or pacemaker manage. Want more on any conditions tests, treatments, or pain differences?
Tell me about pulmonary causes now. Pulmonary embolism, pneumonia, and pleural effusion, and I want us to compare these and talk about investigations and management. Do it in a nice systematic way where I can kind of think about it critically, okay?
All right. Let's compare pulmonary embolism, PE, pneumonia, and pleural effusion, focusing on their chest pain, causes, investigations, and management in a clear, systematic way to help you think critically. I'll keep it concise, using short phrases and organizing it for easy comparison. Comparison of pulmonary causes. Condition, chest pain. Cause, key features, bowl. B, cause, key features, PE, bowl. D, responsive. B, key features, PE, bowl. D, blood clot blocks lung artery. Shortness of breath, fast heart rate, low oxygen. PE, pneumonia, sharp, localized, worse with cough. Bacterial viral lung infection, fever, cough with phlegm, chills. PE, pleural effusion, dull, heavy, worse with deep breath, fluid buildup in pleural space, breathlessness, reduced chest movement, investigations. Pulmonary embolism, PE, tests. CT pulmonary angiogram, gold standard, shows clot. D-dimer, elevated, rules out if low. ECG, S1, Q3, T3 pattern, VQ scan. Why? Confirm clot location, assess lung perfusion, rule out other causes. Pneumonia, PE, tests. Chest x-ray, consolidation, patchy opacities, sputum culture, blood tests, high white cells, CRP. Why? Identify infection source, confirm lung involvement, guide antibiotic choice. Pleural effusion, tests. Chest x-ray, blended costophrenic angle, ultrasound, fluid volume, thoracentesis, fluid analysis, LDH protein levels. LDH protein levels.
Okay, I want to shift our focus just for a bit on what heart failure is, and I want us to briefly talk about the Frank Starling law. And perhaps talk a bit about low output versus high output heart failure too.
All right, let's dive into heart failure, the Frank-Starling law, and compare low output versus high output heart failure, keeping it concise and clear with short phrases for critical thinking. Heart failure overview. Condition, heart can't pump enough blood to meet body needs. Symptoms, shortness of breath, swelling, edema, fatigue. Frank-Starling law. Definition, heart pumps more blood when filled with more blood. Increased preload stretches heart muscle. Relevance, in heart failure, this fails. Overstretched heart pumps poorly. Low output versus high output heart failure. Type, cause, key features, investigations, management. 1. PE, disoperation. 2. Asymptomatic, low output, weak heart, e.g. heart attack, cardiomyopathy, low cardiac output, cold extremities, weak pulse. Echocardiogram, low ejection fraction, BNP, high, ECG, ACE inhibitors, beta blockers, diuretics, ICD. 2. High output, excess demand, e.g. anemia, hyperthyroidism, high cardiac output, warm extremities, fast pulse.
Okay, so in 2 sentences, remember, the next 500 messages, I want you to be answering each time in 2 sentences. Now, let's talk a bit about systolic versus diastolic heart failure. So maybe systolic is ischemic injury, volume overload, pressure overload. Maybe diastolic is hypertrophy or something else. So let's talk about that and in general some causes of heart failure and cardiomyopathies.
Systolic heart failure from weak heart pumping, low ejection fraction is often caused by ischemic injury, volume overload, or pressure overload. Diastolic heart failure from stiff heart filling poorly stems from hypertrophy, fibrosis, or restrictive cardiomyopathy. Common heart failure causes include coronary artery disease, hypertension, and diabetes, while cardiomyopathies like dilated, stretched heart, or hypertrophic, thickened heart also weaken cardiac function.
Okay, and what is the NP system? So tell us about proBNP, anti-proBNP, BNP, active diuresis, vasodilation. So it's basically, yeah, tell us.
The NP system involves natriuretic peptides like BNP and NT-proBNP, released by the heart under stress to promote vasodilation, diuresis, and reduced blood pressure. ProBNP is cleaved into active BNP, which drives fluid excretion and vessel relaxation, and inactive NT-proBNP, a biomarker for heart failure diagnosis and severity. Want more on their role in heart failure or diagnostic tests?
Tell me about alpha 1, alpha 2, beta 1, beta 2. So in the central nervous system, sympathetic outflow, we have alpha 1 and alpha 2 that increase renal sympathetic activity. I wonder why these two specifically. We have alpha 1 that increases vascular sympathetic activity, and beta 1, beta 2, and alpha 1 which increase cardiac sympathetic activity. I'm a bit confused with how to remember this.
Alpha 1, alpha 2, beta 1, and beta 2 are adrenergic receptors activated by symptomatic outflow, with specific roles. Alpha 1 constricts blood vessels and boosts cardiac contractility. Alpha 2 reduces symptomatic outflow and increases renal symptomatic activity. Beta 1 speeds heart rate and cardiactility. Beta 2 relaxes bronchi and vessels. To remember, alpha 1 is for vascular squeeze and heart push. Alpha 2 dials down central signals but ramps up kidney nerves. Beta 1 drives heart pace, and beta 2 opens lungs and eases vessels.
Can I ask about costochondritis? What is this?
Costochondritis is inflammation of the cartilage connecting ribs to the sternum, causing sharp, aching chest pain, often worse with movement or deep breathing. It's typically triggered by injury, strain, or infection, and is managed with rest, NSAIDs, or rarely, steroid injections. Want more on diagnosis or how it differs from heart-related pain?
Tell me about shingles too.
Shingles is a painful rash caused by the varicella zoster virus, reactivating in nerves years after chickenpox, often on one side of the body or face. It causes burning, sharp pain, blisters, and sometimes nerve pain, post-herpetic neuralgia, treated with antivirals, pain relievers, and vaccines to prevent. Want more on complications or prevention?
Also good. Okay, let's talk a bit about the thoracic cage and some about anatomy. So we've got, make us a solid introduction. This time just as an exception, tell 4 sentences. And then I'm going to ask you about sternocostal, costochondral, costovertebral, and costotransverse.
The thoracic cage, a bony framework protecting the heart and lungs, comprises the sternum, ribs, and thoracic vertebrae, forming a resilient yet flexible structure. 12 pairs of ribs connect via joints to enable breathing and safeguard vital organs. Its anatomy supports respiratory mechanics while anchoring muscles for posture and movement. Understanding its joints clarifies how the thorax balances stability and mobility. Now, about sternocostal, costochondral, costovertebral, and costotransverse joints. Sternocostal joints link ribs 1-7 to the sternum via cartilage, allowing slight movement for breathing. Costochondral joints connect ribs to their costal cartilage, rigid for structural support. Costovertebral joints tie ribs to thoracic vertebrae, enabling rotation during inhalation. Costotransverse joints between ribs and vertebral transverse processes permit sliding for rib elevation. Want more on their role in respiration?
I want to shift our focus just for a second back to heart failure, and I want to talk about left-sided and right-sided heart failure, congestive cardiac failure, biventricular failure. Tell us a sentence for each and explain the differences, perhaps even 2 sentences for each, and then I want to talk about how we can treat, but let's do the treatment in the next message.
Left-sided heart failure occurs when the left ventricle can't pump blood effectively, causing lung congestion, shortness of breath, and fatigue. It's often triggered by heart attack or hypertension, leading to fluid backup in the lungs. Right-sided heart failure happens when the right ventricle fails to pump blood to the lungs, causing swelling in legs, abdomen, and liver. Common causes include left-sided failure or lung diseases like COPD, leading to systemic fluid buildup. Congestive cardiac failure, often a mix of left and right failure, involves fluid buildup in lungs and body tissues, causing breathlessness and edema. It reflects widespread heart dysfunction, commonly from coronary artery disease or cardiomyopathy. Biventricular failure involves both ventricles failing, combining lung congestion and systemic swelling, with severe symptoms like extreme fatigue and breathlessness. It often results from advanced heart disease or conditions like myocarditis affecting both sides. Differences: left-sided failure primarily affects the lungs, pulmonary edema, while right-sided affects the body, peripheral edema. Biventricular failure combines both, and congestive emphasizes fluid overload, which can occur in any of these but often implies both sides are involved. Want to dive into treatments next?
Let's talk about loop diuretics, mineral corticoid receptor antagonists, ACE inhibitors, and give us an example for each: furosemide, plerenones, spironolactone, ramipril, and explain how exactly they're helping. And beta blockers, maybe bisoprolol.
Loop diuretics like furosemide block sodium reabsorption in the kidney's loop of Henle, flushing out water to reduce fluid overload and ease lung or leg swelling and heart failure. Mineralocorticoid receptor antagonists like spironolactone, not pleromone, which isn't a drug, block aldosterone, reducing sodium retention and heart strain, lowering blood pressure and edema. ACE inhibitors like ramipril relax blood vessels by blocking angiotensin II, decreasing heart workload and improving blood flow. Beta blockers like bisoprolol, not propranolol, which isn't heart failure specific, slow heart rate and reduce pumping demand, stabilizing heart function and preventing worsening. Want more on dosing or side effects?
I want to ask about sacubitril, valsartan, which are ARNIs. Explain what ARNIs are. Digoxin, explain us the action of that. SA blockade, like ivabradine, explain that to us too.
ARNIs, like sacubitril, valsartan, combine a neprilysin inhibitor, sacubitril, boosts natriuretic peptides to relax vessels and reduce fluid, with an ARB, valsartan, blocks angiotensin II to lower blood pressure, easing heart failure strain. Ivabradine, not a blockade, slows heart rate by inhibiting the heart's pacemaker current, IF, reducing cardiac workload and heart failure without affecting contractility. Note: doxycytin isn't a standard heart failure drug. Did you mean digoxin? Digoxin increases heart contraction strength by boosting calcium in heart cells and slows heart rate, helping heart failure symptoms. Want more on side effects or a correction on doxycytin?
Tell me about SGLT2 inhibitors and dapagliflozin, for instance. And tell me about CRT, biventricular pacing too. And SICD and transvenous ICD.
SGLT2 inhibitors, like dapagliflozin, block glucose reabsorption in kidneys, promoting sugar and fluid excretion, reducing heart failure strain and hospitalizations. Cardiac resynchronization therapy, CRT, with biventricular pacing, uses a device to coordinate ventricle contractions, improving pump efficiency in heart failure. Implantable cardioverter defibrillators, ICDs, including transvenous ICDs, deliver shocks to correct life-threatening arrhythmias, implanted via veins to the heart. Want more on mechanisms or indications?
I want to ask about quiet breathing now. So, actually, tell me one more time about CRT and SICD and transvenous ICD, and then I want to ask about quiet breathing. I was going to ask about the muscles involved versus forced breathing.
CRT, cardiac resynchronization therapy, uses biventricular pacing to sync ventricle contractions, boosting heart efficiency and heart failure. ICDs, like transvenous ICDs implanted via veins, or SICDs, subcutaneous, under skin, Shock the heart to stop dangerous arrhythmias. Quiet breathing relies on the diaphragm and external intercostals, gently expanding the chest for air intake, while forced breathing recruits accessory muscles, sternocleidomastoid, scalenes, and abdominals for deeper, effortful breaths during exercise or distress. Want more on breathing mechanics or device specifics?
Tell me about intercostal muscles. Explain to me the difference between innermost, internal, and external. And also, and they all have an intercostal vein, artery, and nerve too.
External intercostal muscles, outermost, lift ribs during inhalation. Internal intercostals, middle layer, aid forced exhalation. Innermost intercostals, deepest, stabilize ribs and assist exhalation. Each layer has an intercostal vein, artery, and nerve running in the costal groove, supplying blood, oxygen, and nerve signals for muscle function and sensation. Want more on their role in breathing or clinical relevance?
Tell me where they are exactly in the body, like which one is more anterior / posterior / lateral / whatever, medial.
The intercostal muscles sit between ribs, layered as follows. External intercostals are most anterior and lateral, sloping down and forward to lift ribs during inhalation. Internal intercostals, deeper and more posterior, run down and backward, aiding exhalation. Innermost intercostals, deepest and most posterior medial, align similarly to internals, stabilizing ribs. Each layer's vein, artery, and nerve run in the costal groove under the rib, with nerves more medial and vessels slightly lateral. Want more on their anatomical relations or function?
That's good. Okay, tell me about how referred pain works, and also tell me about the motor and sensory stuff regarding phrenic nerve.
Referred pain occurs when pain from an organ is felt elsewhere, like heart pain radiating to the arm, because visceral and somatic nerves share spinal cord pathways, confusing the brain's pain localization. The phrenic nerve, from C3, C5, provides motor innervation to the diaphragm for breathing, and sensory innervation to the diaphragm, pericardium, and parts of the pleura, with irritation causing shoulder pain due to shared nerve roots. Want more on specific referred pain patterns or phrenic nerve issues?
Well, why don't we talk a bit about the diaphragm? So it's got openings. Talk to me about its openings. It's got an aortic hiatus, esophageal hiatus, and inferior vena cava opening.
The diaphragm, a dome-shaped muscle separating the chest from the abdomen, has three main openings. The aortic hiatus at T12 lets the aorta, thoracic duct, and azygos vein pass, not affecting diaphragm movement. The esophageal hiatus at T10 allows the esophagus and vagus nerves through, with a sphincter to prevent reflux. The inferior vena cava opening at T8 permits the IVC and right phrenic nerve, closing during inhalation to aid venous return. These openings ensure vital structures cross the diaphragm while maintaining its respiratory function. Want more on diaphragm anatomy or related disorders?
I want some on what's it called? Sorry. I want to understand these muscles, the innermost, the external, internal intercostals, a bit more, in terms of their location.
The external intercostal muscles, most superficial, lie anteriorly and laterally between ribs, angled downward and forward from rib to rib, aiding inhalation by lifting ribs. The internal intercostals, deeper and more posterior, run downward and backward, while the innermost intercostals, deepest and most posterior medial, align similarly, both assisting exhalation and stabilizing ribs, with intercostal veins, arteries, and nerves tucked under each rib's costal groove. Nerves more medial. Want more on their precise attachments or roles in breathing?
No, that's so good. Thank you so much for watching, guys. Sorry if I was a bit quick with this episode, but I hope you enjoyed it nevertheless. And, as always, peace out.